The next case is a 62-year-old male with a history of hypertension, recent anterior wall MI and severe LV dysfunction. LV ejection fraction is 35%. Angio done at other institute revealed left main bifurcation, Medina 111 with 90% lesion in mid LAD. Major OM shows 90% stenosis and distal OM2 also shows a 90% stenosis. The syntax score is 28 and today's plan is image guided multivessel PCI. Thank you. These are the angiographic images. This is the right. This is the left main bifurcation and first and second major OMs showing proximal lesions. And this is the mid LAD lesion. Over to the cath lab.
Cross the wire to the LAD.
Dr. Saito,
Hi.
Dr. Saito, we are on live.
Hi. I'm.
Model?
Yeah.
Good morning, Dr. Saito.
Good morning. I am very glad to come back here. So.
Which one you want? Oh, we are honored to have you here.
Yeah. That's enough. So, can I have a wire? Which wire do you have? Run through? Okay.
Run through.
So Dr. Saito, just as you're setting up, there's a 7 French radial.
Dr. Saito, we want to
yes.
We want to know what is your strategy
Okay.
in this case.
Okay. First, I took 7 French guiding catheter EBU. Initially, my plan was to do this case by 6 French guiding catheter system, but do you have any insertion tool? Here. Okay.
This one.
But this is a live demonstration case, so for the safety, I instead took the 7 French system. Okay, and this patient has actually double vessel disease, and the right coronary is small, non-dominant. So you can clearly see the very tight narrowing in the circumflex arteries, two parts, and also the ostial LAD, it's extending to left main. There is some narrowing, and also my first target is LAD. Can you? Okay. So first, I want to place this wire to LAD. No. I cannot see already. Just a moment. Yes, okay, this is already. Okay, and I want to keep this wire in this position by the end of the total procedures. Okay, so maybe we need predilatation.
Which balloon you want, sir?
2.5.
2.5 NC balloon.
Yeah, cranial.
The plan is
So what
pre-dissection.
would be your strategy, Dr. Saito?
First, I want to fix the LAD regions.
Mid
and-
lesion, LED
and
mid
then
lesion.
I want to leave the wire in LAD, and then I want to take the second wire and fix the two regions in the circumflex artery,
Yes.
and then I want to place stent from left main to LAD and do pod technique, and then I want to recross the wire to side branch, circumflex, and then finally I want to treat by using the kissing balloon technique.
Kissing
5 by
balloon.
12 and
For the marginals, do you think you could do the marginals without touching the circumflex?
Yes, both,
Yeah. Okay.
because both regions are very tight and not so small.
Correct.
Okay. This is a balloon to LED. No. Yeah. This is fine. This is fine. Okay, just cine. No. Take. Do you have? Okay, here first.
going up.
Yeah, going up. Okay. Okay.
Going up.
Just a moment. Oh, yeah, here. Yes.
Dr. Saito, there is a healthy segment between the mid LED and ostial LED and left main. Will you keep this segment alone or
Yeah.
overlap the stent ultimately?
I want to, anyway, I want to first fix this middle LED regions, and I first predilate it. Okay. Are you ready?
Wire is too deep.
So, can I have 275 millimeter stent? Do you have?
Length is
Or 3 millimeter stent?
30, 32. Which length?
Yeah.
Length
Length is a long one, 38.
38.
Yes.
2.75, 38. So the wire is too deep, I think. Wire is too deep, distal end.
Yeah.
Ah, it's
And then after placing stent, I want to observe by IVUS. Okay.
fine. I was ready.
Okay.
Dr. Saito, do you have any choice in this mid left main any stent?
Yes, at least I have to take the 4 millimeter stent for left main and the proximal LED.
For mid lesion, do you have any choice of a stent? As because there is no significant side branch, so we can put any stent.
Yeah, we can put any stent,
Yes.
I think. Yes, okay. Test.
Okay.
Okay, here.
That's all right.
So 12, 14, 16,
12, 14,
16.
16.
Okay, 16 atmospheres. Okay. Then check by using IVUS.
Just check it. Okay.
And with this IVUS Dr. Saito, you'll check the left main as well and make it.
Yes, of course.
Okay.
Okay.
So we start.
Yeah.
Is it possible to see the images of the IVUS?
No screen. That's all.
This is a distal site. Yeah, distal site.
Yeah,
we can
stent is coming.
identify Stent. There are no damage at the edge, right?
Can you display the IVUS images on the screen, please?
Can you see IVUS?
Yeah, we see them.
Okay, great.
Yeah, okay.
Yeah, I think the expansion is good. Oh,
Flash.
Okay.
compared with the distal portion, this portion is a little bit under expansion, right? And here is okay. So,
This is deformed.
yeah,
Compressed.
plaque volume around the stent is not so big, right? And coming proximal site,
And also I want to check left main.
I see, okay. Okay, generally speaking, expansion is acceptable, but some part small under expansion, but yeah, it's a very concentric plaque, fibrous plaque. Edge is okay, right? Yeah, no problem. Yeah, some fibrous plaque here and very concentric, right? The size is around, yes. Here comes sheath, might be, and here is a left main.
4 millimeter.
4 millimeter, right?
This is a proximal LED
I'm
region.
sorry, yeah, this is a proximal LED, yes. CX is not coming yet. Yeah, here we come, right? Yeah, yes. Right.
Okay.
Lots of fibrous plaque, right?
Okay.
Okay.
Thank you.
So try to check again the left main. Yes.
So, go to.
Order.
And can I have another wire?
Yeah, another run through.
Or different. Which wire? No, any other wire? Do you have?
Any other? Which one, sir? Which one?
How to measure? Yeah.
Asahi.
Medium to medium, right?
Xion.
Right. 7.8, right? 4.8 and yeah. 4.8 and.
Can you
4.8,
switch
yes.
the reference to SAC?
Okay. Caudal view here, sir.
Okay. Left main. Yeah. It's on the no.
This view.
Yeah.
Yes.
Yes. Left main. Yes, that portion. Yeah.
Can you take a picture after dilatation?
Right.
Okay.
Okay. So, Dr. Saito, proximal LED by IVUS size is EL to EL is 4.8.
Okay.
And the proximal left main is EL to EL is around 5.2. 2 or 3.
Okay.
What is the minimum lumen area of the LED?
Okay, I try to check. Yes. Just distal to the bifurcation. Area is 3.8 square millimeter, right?
Yep.
The MLD is 1.85, right?
No. No. Very gently. No. This one is more difficult than I expected.
Dr. Saito, will you like to assess the ostial LED with FFR?
Pardon?
Functional assessment of ostial LED by FFR?
FFR? Okay.
Yeah, I think after treatment of the mid portion, I think the proximal LED is a very discrete region. So resting indices may miss to identify the degree of stenosis in this case. So as you said, FFR should be better to identify if you want, yes. But the area is only 1.8, I think. 1.8, right?
Is
So
2.9?
2.9, right? I forgot. Yeah, so, 3.8 square millimeter. Diameter MLD is 1.8, right? So I think the big LED and that might be significant.
There is another thing that is to be observed here is that you have a post-dilation, so positive remodeling after the stenosis of the ostium of the LED, and that happens quite often when the stenosis is significant.
Yeah, I agree, but left main is much bigger, right? As I already explained you, here is a proximal LED. The diameter is ear to ear is 4.7 or 4.8, and proximal left main distal 5.4, right? So, yes, I agree. Yes, post dilatation, but still the left main is much bigger than the proximal LED.
Test. Okay, so the size of the stent
After
is
big branch, the
for
vessel
this
diameter suddenly
region?
change. So in this case, the CX is a huge area supply, right? Therefore, after CX, yes, we can expect the diameter change in the proximal LED. I agree, yes.
Okay.
Which side you want?
So there is some aneurysmal dilatation. So maybe we have to take 3.5 millimeter stent for this branch.
3.5.
3.5.
Distal is not a thing. Distal is
Think
not.
Distal is smaller. Yes, of course. Or we can place the stent just only for the most significant part. So 3012.
312.
Yes, 3G.
And so everyone knows, was that a 2.5 balloon for predilation?
Yeah, 2.5 by 12 and sit.
So the plan is just a short stent to cover the very tight lesion there.
Stand.
Dr. Saito, which is the proximal landing zone of the stent?
Proximal?
Proximal landing zone.
Proximal landing zone is just after the aneurysmal dilatation.
So it is in the main distal circumflex.
It's aneurysm. Stent is coming.
It's coming, yeah. And will you plan to do IVUS here after the stent?
312. Stand, Joseph.
Should be interesting.
3 by 12.
Okay. 3 by 12.
And thinking ahead, Dr. Saito, so when you've done both the OMs, you'll do a provisional of the left main, and then jail the wire, and then maybe kissing?
Yeah, of course. And before doing kissing, I want to take the pot
You do
technique.
pot before kissing. Yeah. And you routinely do kissing for the provisional approach of the left main?
Yeah.
And meanwhile you're working, can we review the IVUS again? Because angiographically it's not impossible to think also of just stenting the ostial LED and spare the bifurcation, but maybe IVUS will tell us different story.
Coming. Okay.
We'll try and figure
Test.
that out here. Can you see the IVUS there?
Too far?
Yes,
too
they're
far.
getting it.
Here. Here. Okay.
Going up.
Okay. Sine. Okay. This is fine. Stent dilatation.
It's a 12.
Okay. So then take the IVUS. Okay.
I was.
So Dr. Akasaki, I think the question from the moderator was whether you could just do a focal stent of the ostial LAD based on IVUS. That was the question came.
Yes, I'm sorry. Yes, if I can show the IVUS, it might be very easy to explain, right? Here is, no, you cannot see the IVUS, right? disease is yes, continue to the just proximal, right?
We have the IVUS view, but it's frozen.
Can you see the IVUS now?
No, we are getting a frozen image, sir.
Right.
That is previous image. We are not seeing the run.
We are now taking a IVUS. Yeah, I will explain. Can you see the IVUS now? The real time IVUS. Yes, yes. It is the stented portion in the LCX, right? OM.
Yeah,
right?
coming to aneurysm.
Yeah.
Okay, this is aneurysm. I think it's perfect. No? Yeah, no, not necessary. Stop.
Stop.
So how do you think?
Okay, try to review, right?
Okay, can we
Here might be the
have
distal
introducer?
edge of the IVUS, the CX, right? And here is a stent, right?
And the torque.
Yeah. Expansion is very good. Here we have one, yes. And here is the proximal rounding zone, right? So Dr. Saito put 3 millimeter,
This
12
one? No.
yes.
I have to make a bend, a strong bend.
Okay. Yeah, wait a moment.
Dr. Akasaka, can you show us the ostium of the
LAD.
OM?
Yes, yes, OM.
That what we have stented just now with proximal part of the stent, beyond the proximal part of the stent.
Okay, wait a moment. We are now measuring the MRA 5.2 square millimeter, right? After putting a stent, and then move to the not yet. We cannot check the ostium, right?
Yes. Okay, thank you.
Test.
And the previous question, we will move to the LED. Can you see the IVUS, right? Okay, right.
Very difficult.
I'm just putting back to the proximal LED, right? Here is the landing zone, I hope. And this is the just proximal LED. You have lots of disease, right? Here and here, right? Here is a CX. Right.
But anyway,
Here
I
is,
cannot
yes,
point
just
the
distal to
ostium.
the CX branch. It might
Maybe
be very
we
difficult
need
to put a stent.
hydraulic wire.
Just, yeah. So it might be better to
No.
cross.
No. Do you have a
Crossover
XDR
should be
or
ideal, right? And
you have? Okay.
here is the left main, and here also the left main distal some disease you can identify, right?
Yeah.
Okay.
So the answer is very clear. We have to go for left main LED stenting.
Yes, yes.
And that is the beauty, I think. That is also a reason why sometimes it's very interesting to do this kind of imaging, because angiographically you could have thought that an ostial stenting was possible, and just doing imaging you just understand indeed that all the what we see on angiography is sometimes eluding.
Yes, I agree. Yes.
Dr. Akasaka, will you like to comment something about carinal shift in case we are planning to go ahead for, say, ostial LED stent instead of the crossover? Can you comment something about, say, branch point, carinal tip angle distance, and the angle as well?
Yes, I try to check the angle, right?
And meanwhile, have now IVUS of the ostium of the L6 as well, when you do have a pullback from OM1 or OM2?
Yes. The angle is, the carina angle might be more than 50 degree, and from the tip to the branch start might be more than 10 millimeter, I think. Try to check. So we cannot speculate any carina shift to the compromised result, right? So that is the IVUS findings.
Can I ask one question about the strategy for this OM? Will it be to stent back into the proximal circumflex, or are you going to spare the ostium of this OM?
No, I want to stop at the ostium OM. But anyway, at this moment, the wire selection is quite difficult.
There's some challenging wiring here. So you now have a field XT.
Can we change the view to see the ostium very clearly of OM2? Go to deep
on
epicaudal.
You mean on angiogram or on IVUS? For the question about the ostium of OM2, you mean on IVUS? On angiogram?
In this kind of situation, if we have a dual lumen catheter, it's much easy. But from here, again, it's difficult.
Dr. Nata is asking that why not to change a view to...
We can change the view to see the ostium very clearly. Then we have a easy to pass the wire. Or we have a microcatheter twin pass to get negotiation good.
Well, I think that it was maybe been the case for the previous case, but here the view is quite good, so I think it's not a question of the view.
Okay. Any other good projection? I think this is the best one. Do you have a double lumen catheter? No?
Double lumen catheter. Double lumen.
You think putting a wire in the distal circ, a second wire to straighten out some of the subtle curves?
So he's modified the bend now, so to me it looks like a perfect bend, so let's see.
Can you make the more proximal, more closer? It's very difficult. Difficult.
All the difficult jobs will be done by you and it is easy for you.
So we don't have double lumen catheter?
No, we don't have.
We don't have. I see.
Size, do you think a single lumen microcatheter will help straighten out the proximal problem?
Yes, I'm thinking that.
Shall we see what single lumen microcatheters we have?
Yeah.
We are also thinking
What
for
microcatheters
microcatheter.
we have? Single microcatheter, fine cross? Usually if you ask for other equipment, then the wire will go. So this is a blessing.
No. So, microcatheter, please.
How about a pilot 50 wire? You think maybe something different?
Maybe.
So we you can put this wire in the distal LCA
Yeah.
straighten the curve and then possibly can go with another wire for the OM1.
Flash.
Fine cross.
Yeah, flash. Okay.
We can get the help of balloon deflection technique in wire. We place two wire one in the circummate and then inflate the balloon and then negotiate the main vessel by prolapse technique after inflation of the balloon. So balloon deflection may help in this situation.
So balloon is blocking the distal lumen.
Exactly. And then by prolapsing wire in, negotiated in the your OM2 side branch.
Okay.
Back.
This one. The curve is fine. Okay.
Meanwhile, Dr. Saito is working for having a little discussion here between the moderators. I think that what we see here is quite often, happens quite often, especially in the circumflex, because the difficulty here is based on two things. So if you want to cross with the wire and first of all get yourself engaged in the circumflex with that angle and then have another angle that facilitates the entrance of the side branch, it is quite difficult sometimes that with the one shaping of the wire you could accommodate both of the curves. And that's what brings the difficulty in this case. On top of it, when you have also calcifications at the entrance of the side branch, makes it even difficult because they are limited to some type of wires which have some properties that are sliding more easily but that are probably not as easy to handle in the angulation. So probably the idea here beyond this of taking a microcatheter is to first engage a wire, bring the microcatheter in, and then take a properly shaped wire that could tackle that side branch. I think that is what Dr. Saito is trying to do now.
Thank you. Thank you for your good explanation.
Whisper wire have a property of prolapsing. So whisper can help in this situation.
Torque transmission is quite impaired. Yeah. Pilot 50, please.
Dr. Saito, what if you pull the guide just a little back to make it point
towards
the circle?
Yeah, I'm making that. I pulled back the guiding catheter.
And the torque transmission has gone with this wire,
yes.
so he's going to change the wire?
Yes, I want to change the wire.
What Owen was saying was very true. The multiple angles in the big vessel makes it hard to direct, and then you have a calcium
Pilot
that
50?
adds to the complexity. So here we're going to change to an Asahi Pilot 50 inside the fine cross microcatheter.
And any other hydraulic wire do you have?
Whisper is, I think, is the best option because it has also prolapsing property.
Whisper.
Pilot 50 probably would be good, I think.
There are two parallel OMs. Why we cannot leave this OM?
And the cyan?
I think we had the
cyan hydrophilic wire.
I think we had the Sion Blue as our first wire, and then it was Fielder XT, and now the P50.
The pilot should go. We're praying for you.
I think the last one, the torque transmission of the Fielder went, so fresh wire I think will be.
Just I'm asking, there are two parallel OMs and this is smaller compared to the OM we have stented. So can we leave it?
It's always a good question. It's quite a tight lesion. I think the plan for Dr. Saito is to continue to try that.
I think the condition of our back will decide that.
It's a pretty big territory OM though, OM1. I'm sure Dr. Akasaka would use OCT to find the side branch origin.
But I think if we treat the bifurcation first, after then it might be much more difficult to get an OM, right? So I think Dr. Saito tried to OM first before putting a stent in the bifurcation, right? I speculate. Ah, good. Get it. Yeah.
Okay.
Yeah, great.
Now there's Pacific flag there.
That's where the calcification is. That's difficult.
Yes, here is a calcification. So it's quite difficult to cross the wire.
So that's why we understand that it was a great decision to take a microcatheter, so you can have some support now.
Just a moment.
Subintimal. You think it's going subintimal there?
So, still it's quite difficult.
Looks awfully straight at the tip, isn't it?
Tip is not moving freely. Might be subintimal.
I don't know. But anyway, I have no other selection. Okay?
No, I think it'll, the microcatheter is going to help.
Introducer, please. Maybe this is fine.
Maybe pull the microcatheter back a little bit?
Yes, I know. No. Just a minute. So guiding it out. No. So...
We're so sorry to comment. We know you're working hard.
Thank you.
We apologize for that.
Do you have a Sion?
No.
Sion. Sion blue. Okay.
Dr. Saito, we have Sion blue.
Yeah.
This wire.
We already have.
Okay.
Remove this one.
Just keep. Come.
Does anybody on the panel there ever use the reverse wiring technique with a single lumen microcatheter? I know most of the time we use a dual lumen to do that, but you can do some modifications do with a single lumen. Sam or colleagues on the panel?
Dr. Saito has described it, I think, many years ago for diagonals with difficult ostium. My N is 1 actually, so I've used it once.
And we can also use like the export catheter. It doesn't have to be a dedicated dual lumen, right? We can use that thrombus aspiration catheter.
That is a great idea. You know, we use the Supercross 90 or 120. It works very well.
Sometimes even a guide extension catheter to come into proximal vessel just to straighten out the bend with more force than a microcatheter. That would be something. But
those are all great recommendations.
The difficulty here is though not really engaging, but it's advancing because that calcification is a couple of millimeters further, and that makes it difficult. So the only chance that you have here is getting somehow the catheter, the microcatheter, very close to that ostium, and that will, and then switch for a Gaia 2 or something. That could be an idea.
Yeah, these are very challenging when you're trying to manipulate the first few millimeters.
Exactly, that's what we all feel here.
I know back in the old days we sometimes would cut 2 centimeters of the tip off the wire just so we have that more control, but that's not a great thing when with modern wires and when you have a very complex lesion. I feel confident.
Yeah, that's all it is.
I think that gooseneck deformity at the ostium is what takes away all the torqueability.
Exactly.
So I think he's doing what you guys were suggesting, which is try and bring the MC up to the...
I think Dr. Saito's skill is demonstrated here. Most of us would have prolapsed the wire 20 times by now.
25, so.
I agree.
That's extremely challenging maneuver to do, yeah.
Very difficult.
For us, Dr. Saito.
Out.
Dr. Saito, do you think a thrombus aspiration catheter as a dual lumen catheter?
I don't think so.
The only catheter that could offer here some support is a catheter with a side hole, because then you could get that just exit outside there and have the support. It's the closest way you can get to that. But if you don't, then to be honest, in my experience, I almost never have used it. But this is the case that could help.
Gaia first.
Gaia first.
What? I'm sorry, we couldn't hear you.
Well, no, there is a catheter that has like a side hole.
Yes.
It's called dual catheter.
The twin pass, yeah.
The twin pass, yeah.
Twin pass would help, yeah.
Yeah, because it brings you very close to that.
Either that or a microcatheter with a tip on it, which is curved, which will let you engage the ostium.
Could, yeah.
But so, you think export catheter you can use the side hole, or it's
you make a hole?
Export catheter, thrombus aspiration, you have the side hole. It's like a dual lumen catheter.
Gaia first?
Gaia first, yeah.
You know, like a thrombus aspiration catheter? Instead of aspirating thrombus, you put your wire through the side hole.
But it's unusual hole, no? We can cross the wire.
It'll take a while. It'll take a while.
Always it's not successful.
One of the things about the CTO world now, we have so many dual lumen microcatheters. There's some great options, Crusade and Redual, I think you were talking about, and also Twin Pass. Each have their own pros and cons. Sam, when you use your dual lumen microcatheters, do you have any particular flavor that you like better? Because there are so many options nowadays. Sasuke.
We use Twin Pass most of the time. Twin Pass is our original one, and we still use that.
And then your directional microcatheter, I mean, like your Venture catheter, you still use that, or you prefer the Supercross that you were saying?
I think since the Supercross came, we have not used the Venture much at all because of the profile. Supercross is very successful for crossing into side branch through a stent or something like this.
But
who makes Supercross, Rajiv? People are asking who makes it.
I can't remember. I think it might be Vascular Solutions or Teleflex.
I think it is Teleflex. You're right.
All I know with the Supercross is that it has a 90 and the 120, and just always use the bigger one.
Yeah, use the 120 because
use the 120.
It
becomes 90.
Out.
Yeah,
it straightens out at least 30 to 40 degrees.
But we did used to use the thrombus aspiration catheters for the diagonal sometimes. Sam, you and I used to talk about this many years ago.
Yes, it could work. I mean, again, it all depends on that proximal angle. I think that is making half of the life difficulties here.
Sometimes you're doing a case and isosorbide mononitrate becomes your next step. Oral. Double the dose.
Double the dose.
Just from the end.
So there was some talk earlier of blocking balloons, and I mean, gosh, I mean, it's in my limited experience with those, the idea is more appealing than the actual execution of it.
I think no, the blocking balloon is a very good technique actually, but it's more for entering,
Yes.
finding the and supporting. In this case, I don't think it will work much, but could be tried because if there is nothing else left.
I think your point was a great one earlier on. It's maybe not the entering, but it's a few millimeters in where we're losing that option.
But even there, you see where the band comes. It's where the wire prolapses, and the balloon can support that.
Yeah.
Yeah, I think it works probably mostly by straightening out the proximal.
Yeah.
But I think the approach that the Dr. Saito has now is perfect because he just advanced you could see that he advanced the microcatheter over the first band. So with the Gaia first, hopefully this will work. Normally the shaping of the Gaia, they say, I mean the Japanese masters, they say that you don't have to do a double band on it, but in this case maybe this could be necessary to get it engaged.
There you go. I think that might help.
This proximal curve can be straightened by putting a wire and also a balloon across the distal LCs, and then possibly we can try to the OM.
Bend more.
What about Dr. Nata has told about a whisper wire in such cases?
I think now dissection is there because by pilot 50, because initially when he was trying, the tip of the wire is fixed. So I think now at this time whisper is not much helpful.
I agree actually, because you see where the problem is, and then if you don't have a support at the tip, then you'll bend.
Sometimes, injecting rotaglide into the guide catheter into the circumflex, it's a crazy idea, but since we don't have a lot of choices, it might be a last-ditch effort.
Could you elaborate on that?
The rotablator lubricant that is there, there have been descriptions for tracking balloons and stents when you're stuck, when nothing is going. Although now the Gaia is entering, so it's a hopeful thing. Here
is a rectangle.
Yes, absolutely. I think you're making the turn, but this is very promising.
You're gone.
I think you're through.
You're through.
No, no. Still, I cannot cross.
No, I think it's in a branch or something. Yes, it's just a right there, right there.
This.
There
yes,
you go.
Yes,
oh my
yes,
God.
Yes.
That is amazing demonstration of technique and judgment.
Okay, I tried to cross this narrowing by
For all
this
of us,
micro catheter.
Learning
Okay, it's
how
easy.
to accelerate the wire.
So can I have a soft wire?
This is amazing.
No,
Very good.
which one we have?
Run through?
Run through? Yes. But already we have used some wire,
Maybe
no?
cyan blue or
Cyan blue,
wire?
cyan blue.
Are you going to use a trapping balloon, Dr. Saito, or you'll
Dr. Saito,
technique?
Just push it.
Just push it off. Yeah.
Were you using the Nanto technique after all this work?
Yes. Yes, yes.
We have to check the first stent for restenosis now.
So, from the moderators, who thinks that just pushing, I don't know, a 1.5 or a 1.2 balloon will go without extra efforts here?
The fine cross just flew across there, so
I think everything
I'm
will
pretty
go.
optimistic now.
Exactly.
Probably
Everything
wouldn't direct stent maybe, but otherwise should be pretty good.
But this explains also how our work is. You need to take the time and take all the necessary steps and step up to your technique. Still, you have success.
I think it was Amir or someone from the panel earlier on.
Push
I
by
thought it was a
12.
very great statement about never
Just a
consider something to be
Pushing,
easy
pushing.
or straightforward,
Oh,
because then
no.
it changes your mindset. It was
Push,
one of you
push,
guys
push.
said that. I thought it was a very, very thoughtful statement.
Whoa,
earlier
whoa,
on.
whoa, whoa, whoa.
We can use a trap balloon.
Yeah, or more high pressure.
16.
No? No? It work.
It should work. Yeah, the 7 guide, it should work.
Okay. Okay, so shall we take a picture? Okay. So balloon.
Balloon 2.
We have a 2.5 millimeter balloon. No?
So he's going to take a regular 2.5 balloon next.
Yeah.
No. Old one.
So looking at
2.5.
the OM2, where the aneurysm is, we don't think that's a dissection. We think that's just aneurysm in the other OM that was stented. Maybe I shouldn't say anything. It looks like it's not flow limiting.
Yeah.
We ignore that and do the first OM.
Maybe it would be good to put a little stent there too.
So this is a very important message. You know, sometimes the hard wire, like for CTO, is working for this kind of, you know, very tortuous, very bending regions. Okay. Okay, differential.
Now we're coming to the second question of this.
Okay.
Do we justify the size of this side branch to put a stent, and from where to where? Of course, we are not going to the circumflex, but who in the panel would think that a drug-eluting balloon eventually could work in this situation, and who would choose still for a stent?
Okay.
I think the plaque burden will decide because of dissections, etc.
Okay.
Yeah. Okay, good point.
So
surprisingly good for the amount of trouble that was there.
Maybe 2.5, 28.
2.528 alpine.
And we're going to spare the ostium, or will we be flush with the ostium, you think? Try and nail it.
I do not want to touch.
Don't want to touch.
28 is enough.
Enough. 2.5, 28.
Dr. Saito, any opinion about drug-eluting balloon over here?
Yeah, do you have a drug-eluting balloon? Drug-coating balloon?
We only have for peripheral. Sometimes we use it in the coronary for instant restenosis as off-label use.
In Japan, it's very popular to use a drug-coating balloon for small vessels like 2.5, 2.5, 2 millimeter, and also bifurcation, and of course instant restenosis.
So on that note, Dr. Saito, so if in this left main in Japan, would you use a drug-coated balloon for the side branch here?
For left main?
For kissing, yeah.
No.
You'd use a regular.
Yeah, because sometimes it's dangerous, you know. When we are taking a drug-eluting balloon in this kind of left main regions, always we have to make some kind of ablation.
Oh, okay.
Coming? Yeah. Test. Oh, more further.
Okay.
Take senior. Okay, here. $12, 14. Okay. And I do IVUS.
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 IVUS ready.
Now Dr. Saito tried to do the IVUS after putting a stent to OM1, right? To confirm the results.
Okay.
Start.
Can we start, right?
Huh? Broken?
Yeah,
okay.
this is a distal to the stent. The vessel is completely normal, I think, by IVUS. We can, here is the distal edge, no dissection, yeah, very good. We can identify the epicardium in 3 o'clock, right? Yeah, expansion is good in this portion. Some plaque, but here is a very eccentric plaque in the 3 to 6 o'clock. Yeah. Right, still some plaque. 3 to 6 o'clock, and the opposite side is nearly normal, right? Very eccentric plaque. Yeah, and still expansion is very good. Right. Here is the calcium, right? The 6 o'clock.
Yes, yes.
Yeah.
That calcium blocked the wire.
Here is yes, bifurcation. And
okay.
Oh yeah, very good condition, right?
Okay.
No proximal edge dissection as well, and the bifurcation is nearly some plaque in the.
So
yes.
introducer,
that might
please.
be okay, right? Yeah.
No, introducer.
No.
I want to change the wire position.
Okay. Main circ.
So
position of the proximal edge is ideal, right? Not protruding to the main branch. Yeah. And the area is 4.3 and diameter is around 2.4.
Getting easier. This wire is
Oh, yes.
yeah.
Yeah.
I want to check by IVUS.
Yeah.
No, it's difficult.
Is that a scion?
Yes, I think so. But already broken at the tip.
It looks like, yep.
I can never control the tip direction.
Right there.
Oh,
I think
really?
Right there, yep, right there.
Yeah.
Right there, you're in, yep. I think you're in.
Broken.
But you still got through, that's amazing.
Okay, shall we check by IVUS?
Was this a scion wire?
This scion.
Does it happen often to you that the tip breaks? Because I've had it a couple of times when re-engaging bifurcations, and I've one or two times even had to leave the tip of the wire inside because you can't get it out.
I think the best tip retention is run through.
Or 15,000.
Okay, from here, within the stent.
Yeah.
Within the stent, yes. Distal part of the stent. We try to pull back, yes. Yeah. So this time we are trying to focus on the aneurysmal portion, right? Big flap here.
Here?
Here, yeah, just, yes.
No problem.
No,
Ah.
I try to check the bifurcation right here. Yes.
Looks okay.
Doesn't look too bad at all. Yeah.
I think so.
Okay. Okay.
Yeah, try to. Yeah.
So no problem by IVUS. So then it's time to place a 4mm stent.
Which one?
Maybe 12.
4 by 12 ostial LED.
Yeah.
Just a minute. Shall we take a picture?
Right. Yes.
Well, just a moment.
We just try to check the IVUS
Ah,
again.
yes, 12.
4 12.
Here
4 by
is
12.
a huge hematoma, right, in the proximal side.
LED, yes. LED.
Right.
Dr. Akasaka, if the IVUS is not convincing, would you do OCT of the circ here?
Yeah, I think here is an edge of the stent, and it starts from here, right, to the 11 o'clock to the 3 o'clock around, right? That is the reason why the angiographically findings, right? And here already we have a calcium here, and still some hematoma, right?
Hematoma, yes.
Yeah, still It's huge.
Cine, just a moment. Okay, here. A little bit more distal. Here.
Oh, that's perfect. Go.
Okay. Okay, go to 15, 16.
16.
Okay, deflate. And can I have a short high pressure balloon?
Which one? 4 size? 4.8?
Yeah, 4 or
4.8 NC.
Or 4.5. 4.5. 8.
Why two short stent for left main? We have no space for port.
Do IVUS? Okay, first I want to check by using IVUS.
Varsal, Vishal.
There's some question again about OM2.
OM2?
Dr. Saito, could you see the IVUS again?
Yeah, just moment before looking at. Could you previous one? Previous one. No, any problem?
Okay, yes, IVUS. You can see the IVUS, the upper portion, right?
But
IVUS.
we did IVUS. We did IVUS, and IVUS result was perfect.
Can you see the IVUS over there?
To do OCT? No?
No. I think.
We could see IVUS here, yes.
Yes, here is the proximal edge, right? And we have Yes. And then intramural hematoma, right?
There is something?
Yeah, just in the proximal side here, right?
Okay.
We have some intramural hematoma, but no entry in the proximal side. So I think we can leave it alone, right?
Okay. Okay.
Dr. Akasaka, could you explain a little bit about the entry in the proximal site?
Yeah, if there are some entry in the proximal site, I'm just afraid to expand much more. But there are no entry site in the proximal site. We still have a hematoma here, I think. But I cannot identify any entry in the proximal site, right?
You mean in the main circumflex?
Yes.
Or into the lumen of the artery? When you say entry?
Yeah, it's at the start of the side branch. You can identify the media here, right?
Yep.
So it might be okay. And try to move to the distal site, right here. I'm afraid some huge intramural hematoma, but still the intima is okay, and we can identify the media here, right?
Okay. So.
Okay.
What will be a statement?
Okay. Can I do IVUS?
IVUS, left main, okay. We already measured.
Okay. Left main.
Dr. Akasaka, which hematoma you will do some interventions?
Yeah, in the distal, if you have the distal edge hematoma, it sometimes expands, and you may have the stenosis, right?
Diagonal.
Yeah.
Huh? Stent? Yeah. Side branch, circumflex.
Circumflex, yes, just coming, right?
Okay, so 4.5 millimeter.
4.5, 8.
8.
8.
proximally to the diagonal. Yeah. This is the diagonal, right? Yes. Yeah, yeah. Can you see the IVUS?
Yes, we could, yeah.
Okay, here you can see the diagonal, right? And then move to the proximal. Just, yeah, proximal to the diagonal, we can identify the stent strut. Okay?
You mean the circumflex, right?
Yes.
છેલ્લું બલૂન સ્ટેન્ડ કરે પછી કેસિંગ કરવું કે
Test. Okay, here.
we go ahead.
Go. 12, 14.
40.
Hi. Deflate.
Dr. Saito, when you put the balloon for pot, where do you position the distal marker?
Distal marker is just at the bifurcation.
At the distal end of the bifurcation, at the ostium of the LED, or inside the middle of the circle lumen?
Just at the left main.
Okay,
left main to LED.
LED, just at the distal end. Right? Yeah.
And yeah.
Was there a rationale for choosing IVUS actually as a guidance in this procedure?
This wire.
Would you touch up the ostium of the LED a little bit with this balloon?
Test.
So I think we're exchanging wires, I think, here.
Yep.
Sam, I think one of the questions from you guys, I'll ask to Dr. Akasaka, your thoughts on OCT of this caliber left main is possible? 4.5?
Yeah, I think possible. I think it's we can control the angle of the guide. We can get a very clear image. Yeah.
Yeah, and here. Okay, I exchange the LED wire to circumflex, and then next step is, of course, I have to re-exchange the wire from circumflex to LED. Okay, so usually I do not do this kind of procedure, but in this occasion, this is because this is a live demonstration, so I intentionally do IVUS.
All right. Yes.
Okay,
yeah.
To LED. So yes.
Yep. Yeah.
IVUS.
I think for the legend, so frequent IVUS is not necessary, right? But yeah, this is a live demonstration. He kindly to try to do the IVUS.
So I think you can realize the effect of a pot.
Yes, yes. Pot is very important to make some modification of the orifice of the side branch, right? So it's quite easy to select the distal
from
cell.
here.
Start. Yes, again, here is this LED, yes. Distal to the stent. You can see the edge, right? The very good condition. Little bit on the expansion I speak.
Yeah.
Here, the upper comes the wire, right?
Yes.
Yes. And a position, only a small incomplete apposition, just proximal site. One strand or something,
Yes.
right? Yes.
So the final step is I want to take the kissing balloon.
Okay. Try to check the wire position in the side branch. Okay.
Dr. Akasaka, mid-LED has some under expansion
Yes,
and
yes,
needs a dilatation with 3 mm NC balloon.
Yeah, mid-LED, not the proximal, just proximal LED. And some,
Yeah,
in the
3.5
expansion, right?
and 3. LED 3.5.
LED 3.5 and a circ 3 balloon. 3 by 12 both 12 size.
3.5 and 3.0 circumflex.
Length is 12.
12. 12.
Okay. 3.5 12 and 3 12 kissing balloon.
So this is the last one?
Yes.
Just check angiogram, that hematoma, make sure it hasn't changed.
We think last.
Yeah. Suck.
Dr. Saito, any explanation for this kissing balloon step when you feel like the osteum of the L6 is okay on angiography?
Suck is this one? Suck.
Is this one.
Okay.
3 in this one.
3.0.
So I think the question was routine kissing. I think Dr. Saito said earlier on that that's his routine. But what about you guys at the panel? Maybe you can share your experience. If it looks perfect by angiogram, will you always do a kiss, never do a kiss, sometimes do a kiss? Maybe you can tell us what you think.
I think since we have treated the circ and we want to maintain wide access, I would kiss even at low pressure. I don't want to dissect the circ osteum. That's my main goal.
Does everyone on the panel feel the same? I've got to say, I probably would not. I would probably leave it if it looked perfect, but I'm always questioning that decision.
If I may say, I agree with you both, because in some situations, but that's why also I come back to my question, since I have started using OCT instead of IVUS, where you see the struts and the whole geography, then you sometimes really realize that you don't have much in front to leave, and that wire will cross anyway, even if you have to re-intervene. So on a hemodynamic problem you will not have. So once you have a kissing in a relatively short proximal part of the stent and two big side branches, the geography of that stent could be deranged, you can have dissection. So I'll also be keen to not do it if it's not necessary.
Okay.
And if the osteum looks good.
12.
12. LED 12.
12.
12.
Okay. I think that's enough.
Yeah.
Okay. I did kiss.
Off with a 4.5.
Yes.
And at the end, I want to check.
Dr. Saito?
Yes.
What is the result to do kiss?
Kiss?
In L6? Because L6 osteum is not peace, as well as no disease, no flow disturbance angiographically.
So that's why I took the 3 millimeter balloon for circumflex.
Whether you routinely open the stent or there is need of down, there is 2 stent is there, infuser need to go there down L6 down so that you open the
I want to
stent.
check SAC. Okay. SAC is not changing.
Good result, yes.
Stable. So it's not necessary to take. Okay.
Report now.
This is maybe the last one, and I want to do final IVUS.
LED.
You ready?
Yeah, just I want to check if this one is
This is the final.
Final IVUS next.
Yeah.
So on the panel, somebody mentioned repot. There was this debate, I know in Korea they showed some data that a final kiss was as good as a repot. Do you feel different on the panel?
No, the previous IVUS run has also shown some malopposition proximally.
Fine.
It's a time to have a report after doing the final kissing before doing the IVUS.
That's Dr. Akasaka. Does it change the anatomy if you do a kiss in
yes,
the left
definitely.
main?
Okay,
Dr. Saito, we usually know that whenever a KBI is done, then report should be done.
Yes, pot should be done.
Yes.
Otherwise, recrossing of the wire is difficult sometimes.
And such a short stent report is possible to avoid that circumflex ostia.
Okay.
Okay.
Hi.
Yes, because whenever we do KBI, then geometry of the proximal part of the stent is distorted, becomes cylindrical, and it should be changed by report.
Okay.
Okay. Yeah.
So, finish?
You are talking about the symmetricity, right? Yeah. Yeah. A report, we make a much more symmetric, but it depends on the size of the left main. Yeah, I think. Yeah. Yeah. Okay.
Thank you, sir.
My pleasure. It's a difficult case.
Can we say the last?
Thank you.
I'm happy.
Last NGO.
Thank you very much for your advice.
Okay, thank you for your brilliant case.
Previous.
So, Gaia next fast was a very important wire in this kind of situation.
Thank you, moderators. We are now getting ready for the